So good afternoon, everybody. Thank you again for joining us today. This is actually part 3 of our series on caring for cancer patients in the midst of the coronavirus. I'm Leah Streuber. I'm here again with our founder and chief medical officer, Dr. Ken Dixon, and we are honored today to have Dr. James Bailey join us. Dr. Bailey is a critical care specialist and is affiliated with the Northeast Georgia Physicians Group. So welcome, Dr. Bailey. And first of all, maybe just tell us a little bit about yourself and how you know Dr. Dixon.
Oh, well, my background was in cardiac anesthesia, and from that I morphed into critical care. I came to Northeast Georgia in 2002, and I met Ken shortly after that. And over the years, I have actually interacted with him, cared for his patients in the ICU, and we've had this nice mutual respect relationship.
Good, good.
And Jim didn't go into it, Leah, but he and I, back in the ice ages, both went to Davidson College, graduating a couple years apart. And then we went on to our further training from there. So we have some old common origins there.
Well, it's a very good school from my understanding, so.
It was sure hard enough for me. How about with you, Jim?
Yes, it's a unique place. It's a challenge.
Yeah. Well, anyway, thank you, Jim, for joining us. So we're going to, as you know, a few years ago, I started SpeciCare, and we've been saving tumor tissue for the last several years, testing it, a lot of it cryopreserved to deliver results back to the individual patients, which is a little bit different than the general idea of curing cancer, as you know from looking at somebody who's taking care of cancer patients. My emphasis in my practice was not on curing cancer, it was on curing the patient sitting there with me. So that's the entire mission of what we're doing, is to try to bring more information, more options back to the cancer patient. Anyway, let's talk a little bit about what's going on with you, Jim. How are things doing in the ICU now at Northeast Georgia Medical Center?
We think that we have moved past the peak. Our census is slowly coming down. It has been, and we're grateful for that, it has been one of the most challenging diseases that we've had to deal with in my career, maybe the most challenging. But our caseload is slowly dropping. We have had to expand our team. We're all basically working quite a bit more than we would normally work. We've all been, I think, stressed about this a bit. So we are exceedingly happy to feel like we might be seeing passing through at least the peak of this first manifestation of the disease.
You don't have enough protective equipment now to make you feel safe?
We do, although there are still limitations. I must say, when we first started, it was quite a concern. We did not have an adequate supply of N95 respirators, and we were using them on multiple days in a row. And as you know, Ken, in my specialty, we do procedures which carry a high risk of exposure to aerosols, specifically intubations. And it was there was a period there where it felt it was stressful because you're just concerned about having enough personal protective equipment to actually make sure that you weren't being exposed to the virus. Fortunately, in terms of our health system, the number of healthcare providers who've actually had this has been pretty small, so we're all really happy about that. But the personal protective equipment is improving now. I noticed I worked a couple of days ago a shift, and I walked there and I saw a big box of N95 respirators there for the taking, which was not true when we first started.
I'm glad to hear that. That text I sent you a couple of weeks ago, I have concerns about those of us past a certain age that are putting themselves out there, and I admire you, and and the other medical care folks undertaking these jobs. What do y'all, is there any planning that y'all can do for next waves? Can you comment on that a little bit?
Well, one of the things that I think the health system did well was they took a large number of rooms up on the 5th floor, which had previously just been regular patient floor beds. They cut holes in the windows and walls and brought in air pumps so that we turned them into negative pressure rooms. And I can't help but feel that that's been one of the reasons why we've had probably a pretty good record with our staff exposures. Those negative pressure rooms are still in existence, will be available for if we do see a second surge or a recurrence, particularly in the fall. In terms of actual therapies, it's been a little frustrating, and I told one of my colleagues, it's a little bit like being in that movie Groundhog Day, because it seems like every day we really didn't have many therapies available. We are now getting we're getting supplies of remdesivir, the one drug that's been shown to possibly have some improvement in outcomes. So we're starting to get that. And obviously, where everyone is hoping that a vaccine program will be moving forward. We will need to continue maintaining the negative pressure rooms. The health system is now trying to stockpile more personal protective equipment in case we do run into another surge.
I have to think that you will, given the lack of herd immunity out there. Wanted to ask you about separation of the COVID medical care from the non-COVID medical care. As we ramp up elective surgeries, care of the non-COVID medical issues that are obviously going on, it looks like to me, if I'm thinking about a big cancer operation, I want to, if I'm the patient, I want to be assured that I'm going to be not cared for by a COVID team. I'm going to be cared for by a non-COVID team. Can you comment, do you have much insight into that, the way it's being handled here? Because I think this is applicable across many other medical settings.
Well, one of the heartening things that's occurred when we first started down with this disease, testing was slow and cumbersome. I can remember my own frustrations with basically the red tape involved in even ordering a test. That has now become much more widely available. In fact, Ken, I had, for about 6 weeks, I was living in a hotel in Gainesville because I did not want to expose my wife. I am home now, and the primary reason I think I could come home was I was able to get a rapid turnaround test demonstrating that I was virus-free. That test should now be available for, certainly we will be testing patients, but it's also something that could be, hopefully will be ramped up to the point that it's available for testing your clinicians to make sure that there's nobody, that you're not going in with shedding the virus and not knowing it. So I think, it's been discussed in the national press over and over again, and almost the point of being a cliche, but really I think testing will be an incredible key here. And now with the rapid test, you get a pretty fast turnaround. It's also my understanding that the test is becoming more sensitive. And initially, some of the tests available had a false negative rate as high as 30%, but that's been improved.
Well, Jim, I want to check your Davidson education. I want to see how long it stuck with you. Okay. So
okay.
last week we had Tony Latai. Tony is he was a great guest, as you are. And Tony is a medical oncologist at Dana-Farber. He came up with a story thinking about why should we test living tumors against drugs and return that information to patients. So I'm going to see if you can figure out what you would do to know what a dog would do if you Poke it with a stick. There goes that reverb. So you got the question. How would you determine what a dog would do if you would poke it with a stick?
Well, in general, you poke it with a stick.
There you go, Jim.
Got an A.
You win. What's the prize, Leah?
Well, maybe we'll take them to dinner when we can all get together again, but you definitely get an A for your answer.
So Jim, the way we do it in the cancer world is we kill the dog, we cut it into sections, we put it on a slide and look at it under a microscope, and then we say, this is what the dog would do when you poke it.
Yeah, excellent analogy.
That's my little plug about what we're doing. One last thing, and then I'll give it over to you, Leah, if you've got another question for Jim. Do you have any advice for those of us? Let me stop for a minute and let the reverb go away. Any advice for those of us not in the hospital, either as providers or as patients, about how we should be handling our lives now in this COVID world?
Well, I still believe that those of us in healthcare, those of us who've had possible exposures, we certainly have a social responsibility to wear a mask because we never really know what we're carrying. I can't help but believe that that's a two-way street, that a mask does protect you. And I know one of the theories that's been bandied about why some patients have such terrible responses to this virus and other people can be almost asymptomatic is it could be the exposure to the viral load. So I can't help but think that if you have a mask and you're trying to socially distance to the maximum, even if you're around someone who's carrying the virus, the viral load you receive will be less and the chances of you having a severe illness will be less. And then, obviously the hand washing. I'm a little perplexed, by the fact that there seems to be some objection to wearing a mask, and I don't really see it entailing your civil liberties. It's a pretty simple thing to do. As I mentioned to someone that, we have rules about we all have to wear pants, and that's not an infringement of our civil liberties. So I think actually wearing a mask is probably a really good idea. I live in a high-rise condo building in Atlanta, and when I get on an elevator, I try to make sure I'm the only one on the elevator. And just common sense things. I heard Atul Gawande on a public radio news, public PBS News last night discussing this, and they were basically common sense things. And what's really interesting is he made the point, given the degree of exposure that we as healthcare providers have had, we've come away pretty good. I mean, yes, we've had a lot of people get it, we've had people die, but we've done okay. And so I think the general public should probably emulate the kind of things we're doing, which is wash your hands, wear a mask, keep away if you're starting to feel, and they have the socially responsible attitude that if you're not feeling well, you're coughing, sneezing, might be a little fever, please don't go out in public.
Well, Dr. Bailey, I think that that's just great practical advice for all of us. And if we just take it back to those very simple steps, it's going to go a long way to keeping us safe, keeping our family members safe. And I know that that's something that we're passionate about. So again, I thank you for joining us today. Thank you and your team at the hospital for all you're doing on the front line. We absolutely appreciate that. And I think that, before we end our time today, that I just want to say, for those of you that are watching, again, SpeciCare is all about providing custom cancer treatments for patients. We want to give our patients more options and new hope. So if you know anybody that has been recently diagnosed with cancer, or if you have family members that are dealing with this very awful disease, please reach out to us and see if we can help you. There's tons of information on our website, SpeciCare.com. You can give us a call. You can send us an email at info@SpeciCare.com. And it's why we're doing these recordings. It's why we're trying to reach a broader audience, because we want to help more people in their fight with this awful disease. So Dr. Bailey, thank you again for joining us. We hope everybody has a great afternoon. And actually, I can't believe we're saying this, but it's Memorial Day weekend coming up too. So we hope that you have a fantastic weekend. So we'll see you again soon on Facebook. Thank you guys. Bye-bye.